afternoon, everyone, and I'd like to thank the scientific committee for inviting me here. I'm going to talk about a method that I do that is bi-level subcision and autologous fat cocktail for acne scars. We know, I have no conflicts to declare. We know that whenever we see acne scars, we have to examine them with the depth and horizontally in terms of morphology. And we majorly see adhesions or unorganized collagen, we see volume loss, and we see topographical irregularities. And for each of them, subcision is usually preferred when we want to clear the adhesions. Energy-based devices or fillers are preferred when we want to improve the volume loss, and topographical irregularities, for that, resurfacing is what works the best. And this is the case that I'm going to discuss today. We are each going to discuss one case. And this particular patient, a lot of fat atrophy because of acne scars, topographical irregularities, and adhesions in the subcutaneous level. This is the video of the whole procedure, and I'm going to start playing it. Always better to mark before injecting the anesthesia or applying topical anesthesia. I'm marking the various dermal irregularities. I'm circling the subcutaneous fat atrophy that is there. You can also use different types of colors to denote what you want to do in which area. This is tumescent anesthesia. I'm using a spinal needle to inject the anesthesia, and we can see the puckering of the skin in that area that shows that we're in the correct level while injecting the anesthesia. The anesthesia concentration I've put on there, it is commonly available. Once that is done, the entry point is made. When you want to do subcutaneous subcision, my preferred method is the tailor liberator, inserting it from near the ears, and then with one entry point we are able to access the whole area. The other hand acts as a good guide to understand what is the depth at which the device is and what direction it is going in. Once that is done and we have released all the scars in the subcutaneous tissue, the next step is fat grafting. So for fat grafting, again, the same tumescent anesthesia solution is used, injecting and spreading out the anesthesia. Then again, for all tumescent anesthesia, wait for about 10-15 minutes for the adrenaline to act. Once that is done, we can start harvesting the fat. This is a syringe lock that you can get with various vendors, which helps reduce the trouble to the palms. Basically, you don't need to keep on holding it, and then you harvest the fat with a negative suction. Injection, now this is bi-level, so what I'm doing is a to and fro motion with a 20 gauge needle. I am subcising intradermally, so it's in the mid or deep dermis. I'm going to and fro. We can see with the direction of needle, and once I've subcised, I'm injecting the fat with the same syringe. So fat is used as a spacer to fill the space that is created post the subcision. Then I'm using a 21 gauge cannula to inject the microfat below in the subcutaneous area where the fat loss has occurred. Once that is done, now nanofat is also used, and I'm going to show in the next slides. When the microfat is filled, I'm doing a 2-pass fractional CO2 here, show the parameters and they'll come again later, and then injecting the nanofat in the remaining dermis. This is how the patient looks post-discharge. Session 2 and 3 were a TCA cross after about 3 months, a TCA cross in fractional CO2, and the last session was a touch-up session for microfat grafting, again after about 3 months. To the post photo that we see, this is a case summary for subcision. We did the subdermal tailor liberator. Intradermal was with a needle. Volume restoration is with subcutaneous and intradermal microfat grafting and fractional CO2 laser. Topographical was with a fractional CO2 laser and TCA cross. This is the whole case summary that I just discussed with the parameters that I use for the fractional CO2 and the amount of microfat and nanofat injected. This is the final result that we have. The post photo is 4 months after the last session, that's 4 months after the touch-up of microfat that was done. And this is in black and white to help appreciate better. The right side, we can see there is still some amount of topographical irregularities that are left. The best treatment for these kind of topographical irregularities is usually a full ablative laser. Now, I've not done that in this patient, and that's the limitation. But if you're able to do a full ablative, we can achieve further improvement in this. This is the same side with the black and white, which helps appreciate it better. The other side. So what are the current challenges that we have in acne scar management? First is standardized photography. It is difficult to get the same kind of photographs, even with a standardized system like the systems that are there. The problem that occurs is when we use flash, it tends to remove the acne scars, and we are not able to appreciate the acne scars as much. So that becomes a challenge to show what kind of scars the patient has. Instead of that, if you use shadow lighting, getting the same angles at each visit is not possible. So the standardized shadow lighting kits are not available, so that is one challenge. Quantitative improvement scales are not there. So to say that it's a 50% result in one patient, your language of 50% in the others is not the same. So saying how much improvement with each method is different. Pigmentation post-full ablation in dark skin again is a problem. If you're doing it, and Dr. Asif is going to speak more about it, but pigmentation is a challenge that we need to handle. The takeaway points: scar morphology needs to be assessed and visualized both in the vertical and horizontal planes. A combination of procedures is a rule because the mixed scar morphology that is there in almost every patient, because if you're not able to combine, if you're giving a single treatment to each and every patient, then getting good results is difficult because each scar morphology is mixed, and that's why. Space filling of subcised area, especially intradermally, does play some role according to me, and fractional ablative treatments are not a replacement of full ablative laser treatments. You do need full ablative laser treatments in some cases. Thank you so much, and this is my email, and that's my beautiful daughter. Thank you.
Thank you, Dr. Chavan. Another a great segue and a great talk.
So we purposely allowed 10 minutes for discussion because some of you may have some questions or need some clarifications on these techniques that we presented. And so if you have some questions, now would be a time to go to one of the microphones and ask that.
Hello, thank you all for the wonderful talk. Just wondering, do you guys have a specific end point when you're using your CO2 laser to avoid post-inflammatory hyperpigmentation, especially in those skin type 4 and 5? And do you have a different end point when you're treating an acne scar in particular?
Okay.
Yeah, when we are doing that, one is looking at the sebaceous glands. You do start seeing normalization of the sebaceous glands, and that is an endpoint. The second is getting to a level where the dermis seems plain, and in these type of cases, the erbium yags with the scanner help better as compared to a manual scanner. If your hand is used to it, then it's good. The third is when you do erbium yag and you start seeing that increased amount of bleeding with a plain surface is when we usually stop.
When I
CO2 laser.
Go ahead.
Another comment is using the cross technique gives you a smaller unit for injury. So the smaller your ablative unit, the less risk of PRH. That's a strategy behind mixing cross with laser. Like a lot of patients complaining about doctors doing 2 or 3 laser treatments and still having scars. So my fear is that doctors will over-ablate, even though the scar's still there, there's no more water left, they over-ablate with CO2, so that's my concern.
One comment that I do when I'm doing that is with full ablation, I don't like, once I see the dermis, I don't want to keep heating the dermis and trying to go deeper. But I will often add fractional ablative laser to some of the more difficult areas with a few passes. But you don't want to be super aggressive with both full ablation and fractional ablation, because then you could get hyperpigmentation or make scars worse. But if you want to go deeper, consider adding a few passes of fractional to your full ablation.
Yeah, I agree with Dr. Taylor, because the issue isn't the hyperpigmentation, because you're gonna peel off that first layer and the skin's gonna be lighter than mine is. But the issue is, if you go to those adnexal structures, even if they temporarily repigment, 6 months, 9 months, a year later, they can completely depigment in those areas. Like there's a shock to the adnexal structures. I think in the future, we're probably going to have imaging that's going to be able to tell us what the depth is. So the OCT or one of the others.
Hi, quick questions, Rullan Cox. That was a great panel. Deciding between, for the cross technique, phenol or like 100% TCA, can you kind of speak to the benefits of one versus the other?
Well, we describe TCA as a cutting agent and carbolic as a vesicant agent. So, Dr. Lim in Australia used TCA successfully. He used a very fine paintbrush. I think the toothpick idea is probably no longer being used a lot. The fine paintbrush is an easy way to control and it's faster. So I think painting a small amount of TCA around the edge is good because it's going to cut down, just like they do with erbium microfocus, collimated. They actually can pare down, like Jill Wable does that. She'll pare down the shoulders of a boxcar, the same we're doing with carbolic. I just like the way that with erbium and carbolic, there's a synergism. I don't get the PIH because it's a very tissue reactive. So that's why, but you could use TCA. Carbolic is better.
And just to add to that, for darker skin patients, TCA has a higher rate of hypopigmentation as compared to carbolic, is what I've experienced.
I think we're out of time, but thank you everybody for your participation and your being here. Thank you.